The most common approaches to blocking the sciatic nerve involve lifting the patient's leg or rolling the patient to access the nerve from the posterior position. This is the case with the popliteal approach about 2 centimeters above the popliteal fossa and the subgluteal approach below the gluteus maximus muscle between the greater trochanter and ischial tuberosity. The sciatic nerve is most superficial from these posterior views, so it makes sense why these are often the preferred techniques. However, lifting the leg or rolling is not ideal for patients with limited mobility due to trauma, frailty, or with external fixation devices. Fortunately, the leg is round, which means we can block the sciatic nerve with the patient in the supine position from lateral and anterior approaches. The sciatic nerve is derived from L4, L5, S1, 2, and 3. These nerve roots combine to form the largest nerve in our body that then exits the pelvis through the greater sciatic foramen. The sciatic nerve is the workhorse of the lower extremity, supplying the vast majority of motor and sensory function to the lower limb. For the lateral approach to the sciatic nerve block, we place a curvilinear probe on the lateral side of the leg in the transverse orientation just above the knee. Here we can identify the hyperechoic line of the femur. Posterior to the femur, we see the bright sciatic nerve underneath the biceps femoris muscle. The popliteal vessels are seen between the femur and the sciatic nerve. We can complete the lateral approach to the sciatic nerve block at this level or scan a little higher to ensure we've blocked the nerve proximal to its division into the tibial and common peroneal branches. We'll advance our needle in an anterior lateral to posterior medial direction, then pop through the posterior fascia of the biceps femoris muscle. Here we give a test injection with saline. After confirming we're in the right spot with our saline test injection, we'll administer our local anesthetic. 20 to 30 mL of volume is a typical dose in most adult patients, and we'll use 0.25% bupivacaine for analgesia. For surgical anesthesia, we'll use 0.5% bupivacaine. In this post-block scan, we see the sciatic nerve well surrounded as it divides into its tibial and common peroneal branches. For the anterior approach to the sciatic nerve block at the level of the mid-thigh, a curvilinear transducer is placed on the anteromedial aspect of the leg. Here we see the sartorius muscle, vastus medialis muscle, and adductor longus muscle at the level of the femoral triangle. Immediately below adductor longus muscle is adductor magnus muscle. Just below adductor magnus muscle, we see the bright elliptical-shaped sciatic nerve. Also notice below the sartorius muscle, we see the superficial femoral artery and the saphenous nerve just lateral to the artery. We'll advance our needle in an anterior lateral to posterior medial direction, then breach the posterior fascia of adductor magnus. After confirming we're in the correct position with our saline test injection, we'll switch to our local anesthetic and administer about 20 to 30 mL. For cases where analgesia and the saphenous nerve distribution is also needed, such as an ankle fracture, as the needle is withdrawn, we'll pause at the posterior fascia of the sartorius muscle just lateral to the femoral vessels. A saline test injection confirms we're in the correct position for a femoral triangle block, and we'll administer about 10 mL of local anesthetic to cover the saphenous distribution. In this post-block scan, we'll turn the probe 90 degrees counterclockwise and see the sciatic nerve in long axis well surrounded with local anesthetic. For the anterior approach to the sciatic nerve block at the level of the proximal thigh, we'll place a curvilinear probe on the anterior medial thigh about 5 to 10 centimeters below the inguinal crease. Here we see the femur, sartorius muscle, the superficial femoral artery, and adductor muscles. The hamstrings are the deepest group of muscles, and we see the sciatic nerve between adductor magnus and the hamstrings. We'll advance our needle in an anterior lateral to posterior medial direction, pop through the posterior fascia of adductor magnus, and give our saline test injection. We'll then administer about 20 to 30 mL of local anesthetic. In this post-block scan, we'll turn the probe 90 degrees counterclockwise and see the sciatic nerve surrounded with local anesthetic and long axis. Remember, the leg is round, and you have options to block the sciatic nerve from the supine position. Whether you approach from lateral, anterior, or posterior, understanding the anatomy in 3 dimensions can improve your success and patient comfort.